Okay, great. I think we've already uh, beaten the machine learning horse quite a bit, and so I think these two presentation just took the raw numerical data. The next presentation is taking us to a different class of data, and that's imaging. As a matter of fact, that's where the uh, sort of burden of industry attention has been IBM with various companies to do that. So, with again, thanks to our colleagues from Australia, we're going to Los Angeles, and we have Dr. Piotr Slomka from Cedar Sinai Medical Center, who's again a computer scientist. Uh, he's been in cardiology for quite a while and knows our lingo as well as his lingo. So, Piotr, are you on the line?
He needs to switch to.
Can you turn on your microphone? We can't hear you. Piotr, can you hear me? We cannot hear you. Your microphone is not on. So we're going to wait a few minutes. And if you can't get your microphone on,
and if you are not going to speak, then we have Dan Burman here to speak on behalf of you.
okay.
Welcome.
Okay, thank you, Dan, for coming. So we have your brilliant scientists online trying to find a way to connect through microphone. Piotr, can you hear us?
You know, this is a problem with Los Angeles actually, and no, because once in India, we had all, there was the 60th year of Cardiology Society of India, and we had 30 people from the United States, all top
Attendees.
marks.
He's on the staff.
Dr. Gromwald could not make it, so he said that he would speak from Los Angeles. And we had absolutely everything very well connected. You know, like we were talking to them, everything is all fixed. Whole hall is full, absolutely standing, 3,500 people waiting for him to speak. He comes on, we can see his picture, but we cannot hear. Now we are like struggling. We just couldn't manage to do anything.
Can you hear me now?
Yes.
Can you hear me now? Yeah. Okay, I'm sorry. I was on the phone. So I had to just call back again. Everything was connected, but never mind. So now everything is okay, right?
Yeah,
yes.
So give me 1 minute.
Okay.
Just a second.
Wait. So
yeah.
what happened was,
all right. So
I had to put Gromwald on my phone and phone on my cell phone, and he spoke. Later on, we realized that the satellite was transmitting to Mumbai, and they had put it on.
Well,
okay.
Thank you for getting through your challenge, Piotr. I think we have now everybody hearing you.
Okay, all right. So let me just start. So I will be presenting machine learning, and you can see my screen now, second screen, right?
Yes.
Yeah. So basically, the previous speakers covered very well the machine learning parts. I will not get into the technicalities, but I like to present a little bit about the work we've been doing in imaging with cardiology, with Dr. Berman and Dr. Min and others, in sort of looking at how we can use it in sort of like kind of going a little bit lower down from the high level now to the low level of how we can actually use it and in some small incremental way improve it. So without getting too much into detail, one thing was mentioned before is that we how we do this, and we build these models, and we don't have to assume particular models. We use this in statistics quite a bit, and I'll show you one example with logistic regression. But here we don't have to actually assume any models. But what is important, and there was a talk before, there was one comment about overfitting. What's important that the testing data is always separate from the training data when we do this, because otherwise we would end up fitting a perfect model which predicts everything from the data the computer already has seen. So the important thing is to test it always on data which computer has not seen before. So I will just very briefly, I won't get into details, but I'll probably spend a couple of minutes on each of these topics. First, I'll tell you about how we improve actually image segmentation contouring with machine learning. And then something very simple using logistic regression, how we can add two scans together to predict better coronary artery disease. And then we move to a paper we published recently about how we could predict revascularization possibly. And then something sort of pilot study, but we showed that actually from CTA, from multiple features from one modality, you could predict results in the other modality. Maybe then you don't have to do that more expensive scan. And then more along the lines of what you've seen before presented would be a couple of studies here. One where we show using imaging CTA and clinical data combined to predict death, mortality. And sort of a preliminary study we just show recently at ASNIC where we predict MACE from fast MPS, sort of interesting results. So I'm gonna move on. So I will, this I don't have to explain anymore. I think this has been covered very well, but I just want to tell you there was a very nice editorial in Circulation, sort of cardiologist friendly on machine learning. And there was a very nice figure there showing, what we're doing here. I think everyone understands. We have many patients, and the patients have many features, and there are some outcomes. For example, MI, myocardial infarction. And the simplest thing you can think of machine learning would be, try find, what kind of cluster of features has, particular patients who, for example, don't have an MI, and then you try to find those kind of clusters or those kind of combinations of features, and you'll say, well, those people who have those kind of features will not have MI in this case. So this is kind of a very basic algorithm, which actually there is an algorithm called K nearest neighbor, which works just like that, but there are much more sophisticated algorithms, as you have heard. So something recently published, just came out a few weeks ago, to show you something sort of not trying to replace the cardiologist, but more on the technology side. Because in nuclear cardiology, we have this big problem. We have this cardiac scan, and when we fit the data, we sometimes don't know where to put the valve plane. It's kind of very tricky. And if you put the valve plane wrong, you get wrong results on your polar map, and everything then, of course, will be wrong. So technologists are, always putting this valve plane in the correct position, and we always have this problem that we always have to quality control this data. It takes a lot of time, and it's also variable. So we were thinking, can we somehow employ machine learning to actually position that valve plane exactly where we would like that valve plane to be, so we don't have to do this manual task all the time. So that's what we have done in this study recently published, where we will look at different image features. So in this case, it wouldn't be some patient features like clinical features, but it will be something what the computer sees on the image. For example, how this peak looks like when you move this valve plane, or what the polar map looks like, or what's the shape of the heart. Is it too long or too short? So when we apply this kind of techniques, we showed something very interesting, and that is when we take two very experienced technologists who do that 20 years or so, the difference is when this technology puts this valve plane is about 8 millimeter or so, and that actually has some effect on clinical outcomes. But when we actually compare it to the machine learning here, SVM, that's the same technique which the previous speaker was presenting. When this computer will look at different image features and then will just put the valve plane where it thinks it should be, learn from those technologies before on some different data set. And we find that this difference is actually smaller than between two experts. And then we also show that it actually diagnostically is no difference. So we actually, with this kind of technique, you could pretty much automate positioning this valve plane in the nuclear scan. So pretty much automating this whole process of extracting all the image features from the images. So that's kind of like a simple example on where we could apply it to detect, to improve image analysis in our data. So moving on to like a more higher level example where we would, in this case, we would want to know, as you know, in calcium scan, you've mentioned calcium scan before, and we know that, for example, on PET CT scan, we often have calcium scan together with PET scan. And the question is, can we somehow combine this data? Right now we don't. Right now we are doing it in some mental capacity of the physician, you will say, okay, well, there is a calcium score and there's this kind of scan. What happens? So can we actually use machine learning and just use, for example, two variables, very simple task, which we don't even do today as it is in the clinic, and can we have like a better way of predicting, in this case, coronary disease, obstructive disease? So we actually, in this case, because it's such a simple example, we actually used just logistic regression, but we use it in a way we would use machine learning. We would try to predict using this kind of a separate populations. And we will come up with, and you probably are very familiar with this kind of technique because this is used a lot in medicine, but it is also used in machine learning. It's like a very basic technique. And with this technique, the nice thing is that you have this kind of equation you can come up, and this equation will tell you, okay, even per vessel, you can have a per vessel calcium score and per vessel TPD. TPD is something we compute here on this images automatically. And we say, okay, there's a 3% TPD, which is borderline, and then we'll have a very little, maybe just calcium score of 1 or 0. In this case, it was 1. And then from this two, we will compute actually a score of obstructive disease probability. So when we do this, we can actually combine it and look at the ROC curves, and then you see here that doing this, you actually improve. This was your PET alone. This is your calcium score, and this will be the combined. And this is done in separate populations using this tenfold cross-validation, and so this is statistically significantly better. So without doing additional scan, we can actually predict the obstructive disease better, and this will be done for any patient. So it's not just for particular score, but you could just plug in the score into this equation. So that's one simple way. But now we were thinking, okay, can we actually apply, use more features and predict, for example, something like revascularization by machine learning? So now we're getting into this higher level techniques like have been described before. And so here is an example from the published study where we will use the image information like this TPD, which we automatically derive from the images, and then some other information like, for example, ST segment depression, or you will use ECG response, and we will use some other scores which are already available, and so forth. And the computer will find rankings of what is actually useful for machine learning, and this is called feature selection. And then based on that, we will then apply this combine all these features combined and try to predict revascularization. And here we use technique called boosting or ensemble learning. And without getting too much into details, the very simple way, intuitive way to understand this is that it's like trying to have three different or multiple different learners. Or like three different observers, three different cardiologists, for example. And when each of them will have a slightly different answer. Maybe each of them is quite good, but they have their strengths and weaknesses. So, but when you combine them, this kind of techniques usually result in better results. So that's what we use. This is called ensemble boosting learning, logic boost. And when we apply this here, and this is kind of a predicting of revascularization by machine learning. And here we have actually experts. So those experts are, this is some different score of two different experts. And you see how the different experts in blue, how they're different in predicting this. The green one would be just the computer image variables. But when you actually add the clinical variables, it becomes much more predictive. And so this is all statistically significant. And you see that there is no really difference in using machine learning for this kind of task versus these experts and actually in this expert was actually this expert 2 was actually much worse than before. So now something just sort of, this is a pilot study where we try to see if it's possible, for example, again keeping separate data testing from training, is it possible to show from CT analysis, and this is work we're doing here at Cedars-Sinai. We do this advanced plaque analysis on CTA, and this kind of analysis, as you see here at the bottom, it can show you. Actually, see if I use a pointer. Yeah. So here you can imagine there could be multiple image features derived from this, and we derive 5 features such as remodeling index and stenosis and plaque volume and so forth. But we also add things like myocardial mass and age and gender. And then if we use that, we can actually predict myocardial flow results by PET very accurately. So this is a small study, but it shows you that per vessel or per patient, you can actually predict flow measurement by PET from those kind of features, including some other additional information about the patient. This is a recent study, so it shows you how you could use machine learning to sort of maybe, economize on some tests, that you could use one test and sort of efficiently use the information as much as possible from one test to predict some other results. And in another study with CTA, we were working with a sort of a larger database where we had 16,000 cases from 12 centers. This is with Dr. Min Confirm Registry. Recently, we published a paper on how we can predict death in this kind of study using imaging and clinical features together. So similar, like with this revascularization study, the computer will find features which are important. And here there's many more features, and at some point these features become not very important. But you see here is a mix of things which are clinical, and then also some image features like for example stenosis and so forth. These image features in this case were manually derived from the Confirm. This wasn't automatic processing of CTA at this point, but you can imagine that it could be. And with this kind of technique, we use this, with this 16. This was actually around 10,000 patients from which this was run on suspected patients with suspected coronary disease. We use this kind of tenfold validation, and importantly, when we do it, we use this tenfold validation where we will use 90% of the data for training and then 10% of the testing. But then we will keep that away and store this result. And then we use another 90% for training and test it on another 10%. So that way we use 10 different models, but every time the data is separate, training data is separate from the test data. And with this kind of result, and you've heard before was the Framingham risk score, you see here in blue, and here is the machine learning in the 10,000 patients. This is 5-year all-cause mortality prediction. So you see that it's pretty accurate. And actually, probably if this was a shorter period, it would be more accurate. But there would be not enough events. So we're just, as previous speaker were talking about it, the data is very important. How many events you have is not how many all patients you have here, but how many events you have. But there was about 900 events here, so this is a pretty substantial population. And you can see that these techniques can be very, very accurate and perhaps useful. And so you can look at it also with this net reclassification index, and you can see here that using this ML machine learning boosting compared to Framingham risk score, the patients can be up risks in red or de-risked in blue. And you can see the total net reclassification index was 24% when you apply this kind of, if you use this as a new score for your prognostic prediction. So those kind of techniques could be used in a sort of a recent study which we have shown at ASNIC here. We show that it actually is very interesting that this is only 2,600 single center study, so we're working on many more cases. This is using fast MPS, myocardial perfusion imaging, and we can build the model and predict it. And what's interesting is that we can then look at the percentile score, because this machine learning score will be this kind of continuous score, which will give you probability, and this will be the actual events. This is a MACE 3-year MACE prediction. And you can see how well it's fitted. So like even here, what was surprising to us, that even at 50%, like this is a pretty high chance of having MACE event within 3 years, 50%. This is the gray ones are the actual rates, and the red ones will be the predicted rates. So that shows you a pretty, accurate prediction to actually what kind of probability we are talking about. So it's a whole range, and especially here also, it's very good. And you see the ROC again, you see this, big jump in accuracy when you use this kind of techniques. So we are actually trying to get more data, get like 10 sites, and get like a more meaningful data sets where we can apply this kind of techniques and develop the scores and have people use this kind of scores, which could be potentially used in clinically. And the last slide I like to show is that there was a question about, this is a black box, and how do we know that what machine is doing? So actually, in a sort of one study, we showed that it is possible to show how the computer arrives at a particular risk score. And there are some techniques which will tell you in a given patient, for a given patient, what particular features were responsible for the high score, and will tell you this, give you this kind of something called rational value. So for this particular case, it was a very high risk score, and it says, okay, well, that was some stress score and age and some rest score and enlargement of left ventricle lung uptake, and this was another study where they were using digoxin. So those kind of features were in this particular model were showing that those features were responsible for the high score. So that would just sort of open up this black box a little bit for the cardiologist to show, what this could be used for. So in summary, what I like to say is that we know that machine learning combines these multiple features, and we can actually combine imaging and clinical data points into one score. We can just put it all together. And we can also use it to train image segmentation that will make our images more accurate to start with, the data which we feed into machine learning. And then we can predict disease, intervention, outcomes in terms of post-test probability. We give this kind of post-test probability for a particular outcome. And I don't think we should worry about the cardiologist sort of worry about replacing it. I think it will be a great tool, a tool which will find the better answer for the patients. I think every cardiologist would like to have a tool like that, which will give them better answers for the patients. So that's everything. Thank you very much for inviting me, and sorry I couldn't be in person there.
Thank you very much, Piotr. This was very nice. I think you wrapped it up very well. You answered also Dr. Falk's fear that it's all machine. What does he learn? So I think the machine can give you some ways in the score. Any particular question? Before we move on, Dr. Narula?
More than a question, it is a comment. I think it was fabulous talk, absolutely fabulous talk. And
thank you.
He has put everything together. It is amazing. And Dan, congratulations to you and your group for what you are doing. And
thank
I think
you.
it becomes much more relevant today. How many of us did we see the future trial presented this afternoon? On the FFR in the multivessel disease, totally tanked. 2.4 times higher risk of having MACE when you are doing it with FFR. So I think the imaging is going to come back. The reason being that if we do what we have been doing together, that the FFR probably is not only predicted by the QCA, it is predicted by the lipid volume also. And the lesions that we are fixing, specifically when there is a multivessel disease and multi-lesion per artery, we are screwing up by fixing the wrong lesion, while the FFR may be caused by something else. So I think this trial today was such an eye-opener that after doing 900 cases, they stopped it. And FFR has gone out of the window. So I think this is amazing what you presented.
Fantastic. Well, non-invasive imaging really has a lot to benefit from machine learning, because there's a lot more information than 6 variables that you have in front of you. And so thanks again, Piotr. We're going to move on.